So we go on to our next presentation, and that will be left main bifurcation PCI by Dr. Ravi Cheriyan.
Good evening to all. Today my talk is regarding left main bifurcation PCI. So this is a 68 years old male, diabetic hypertensive, who is on chronic kidney disease on peritoneal dialysis, presented to us with rest angina with and dynamic STT changes. Initially, he was managed conservatively in view of high risk, but subsequently he developed recurrent episodes of rest angina with hemodynamic instability. Hence, after explaining the risk, he was taken up for a revascularization. So we went ahead with the angiogram. We went with the angiogram. You can see it's a left main disease, Medina class 111. So LAD ostium, we have a tight 90% stenosis. L6 ostium, we have a 90% stenosis. And coming to the RCA part, RCA is a diffusely disease and distally it's totally occluded. So what to do next? It's a calcific bifurcation lesion, Medina 111. So our plan was to go ahead with a rotablation or an intravascular lithotripsy. So this is shockwave IVL. And then plan for a bifurcation stenting for LAD L6 left main with and IABP support. So first initially we thought of rotablation, but later it can develop as complications, that slow flow everything. So hence we thought we'll go with an intravascular lithotripsy. So we first wired both the LAD and LCX with a BMW 014, and initially we pre-dilated the LCX with a 209 to 15 mm sprinter balloons, 2.5 15 mm and 2.75 into 15 mm NC sprinter balloons. And subsequently we pre-dilated the LAD with a 215 sprinter balloon and 2.5 15, 2.75 15 Solaris NC balloons. And this was the result. So then we thought we'll go ahead with the shockwave. So we use a T12 mm balloon for the shockwave. Initially in the proximal we gave, subsequently we gave the distal. And this was the result after the shockwave. Now our plan was to stent the L6 to left main. So we stented the L6 to left main with a 320 mm synergy stent. And subsequently we crushed it with a balloon, the ostium of the L6. Then we stented the distal LAD with a 2.5 into 22 mm Russell Tonix, followed by the proximal was stented with a 312 we used, and subsequently the left main was stented with a 3.5 18 mm Russell Tonix. Then we did the post dilatation. This was the result, and this is the stent. You can see the bifurcation stent, the crush technique we used, and the stents you can see in the left main L6 and the LAD well opened. And subsequently, we did a post dilatation of the LAD L6 and left main with a 3.5 15, 412, 4.5 into 8 mm Sprinter Solaris and U4 NC balloons, and this was the result. Subsequently, we did a IVAS which revealed a well opposed stent in the LAD with a mean lumen area of around 6 we got. And L6 subsequently we did an IVAS which we had a good lumen area. MLA was good. Finally, the kissing NC balloons, kissing was done using the NC balloons. And the left main stent again was post-dilated with a 4.5 mm stent, 4.5 mm balloon. And this was the final result. And after 24 hours, IBP was removed and anatropic supports were stopped. Dialysis was continued. He improved and discharged on the 7th day. Thank you.
Thanks, Dr. Ravi. Are you there physically? Yes, you are there. Thanks. So again, another chip PCI, left main PCI in an acute setting, classical 111 using IVL. We had the first case also using IVL. You got away with pre-dilatation. That was good luck on your side. Otherwise, if there would have been a waste, possibly you would have been forced to use a rotablation. But you could avoid that with pre-dilatation. And the other thing is that in such situations, maybe you may not go for to high pressure dilatation. There was some LED waste also in that ostial, some mild narrowing, but and you said LED was 6 square millimeter. Normally, we at least would like LED to be 9 square millimeter, but in a situation like this, we may not go for avoiding all slow flow, no flow, and all that. You may call the patient back again after or pre-discharge when things settle down, and then follow it up with high pressure dilatation. But I think nicely salvaged, and I hope the patient is doing well now.
Yes, sir, the patient is doing well. Actually, at that time, we didn't want to go for a final fine tuning in that patient because he was totally hemodynamically unstable. So hence, we
Absolutely.
just whatever possible, we just got it done and got the patient out. Now he's doing fine.
Good, good. So I think we discussed many of the things and would not like to repeat, but thank you very much for showing that interesting case.